Hello, my name is Saad Usmani. I am the Chief of the Myeloma Service at Memorial Sloan Kettering Cancer Center, and I'm here with blood cancer today. We are here in Chicago for the ASCO 2023 annual meeting, and we're going to be talking about all the exciting data coming out in multiple myeloma. We'll cover the newly diagnosed setting, some of the approaches to early as well as late relapses in the context of new novel immunotherapies, including bispecifics and CAR-Ts. So I'm looking forward to having a wonderful, engaging conversation with my colleagues. I'll let them introduce themselves.
Hi, I'm Yi Lin. I'm from Mayo Clinic in Rochester, Minnesota.
Hi, I'm Shambavi Richard. I'm from Mount Sinai, New York.
Hello, I'm Meera Mohan. I'm from the Medical College of Wisconsin.
One construct, BCMA CAR-T construct, the FAST-CAR, that Adam Sperling had initially presented at ASH, and now there's a further update. What do you guys think about that data?
So the PHE-885, really interesting at how high these response rates have been. So I think he had about 43 or something patients on that enrolled now. The data is getting, now we have like about a year or so follow-up on it, which is really nice with very high response rates, like 92% or something. The deep response is still catching up because I think some of their patients were still deepening their responses at like 18 months or so. And pretty comparable, I think, in terms of CRS and neurotoxicity. I think they had about 11% with the grade 3 CRS, 7% with the grade 3 ICANS. But, we still need to see what the rest of the numbers are. But so far, it's looking really exciting. And with that, the fast turnaround time with this, less than 2 days. So they had like a 16-day vein-to-vein time, which is really also quite impressive, so that a lot of their folks didn't need bridging because it was short. And that's a really nice thing too, because we have people who progress with bridging or fail bridging. Now they're sicker, their disease is like more out of control. So this is good to have them be a little quiescent right before going into CAR-T. So
yeah, there's absolutely. And I think, literally, this question often comes up, like auto versus allo CAR-T, right? And I really think fast manufacturing CAR-T is really the next low-hanging fruit, because we see there's still challenges with allo cells that hopefully with development will get them to work better or persist longer. So there's still some work going into it. But auto, at least we know right now, even with heavily pretreated patients, we can get cells we can manufacture. So if we can manufacture faster, I have two thoughts related to that. Now, if we saw the PHE-885, and then there's also the GC012F that's also presented. Same concept, different, manufacturing, but both very quick turnaround. But the cells are not infused right away after they're manufactured. So really, if you could make the cells in 1 to 2 days, wouldn't it be great if you can give it back to the patient in 1 to 2 days, or let's say less than a week, so there's no bridging that's needed, right? So I think the question with that is really the regulatory science. You did take the cells outside the patient's body, you manipulated it. What testing is absolutely required for that release criteria? And with all the new technologies we have now for infection testing, quality testing, so on, what can be expedited that the FDA can allow us to use that can still facilitate, in a distributed to center manner, so that these patients could potentially, even get that faster. I think that's an opportunity. The other thing that's very, very interesting to see biologically, it's a fast manufacturing. These cells are potent. It's a phase 1. The dose that's needed to be given there,
it's pretty
much lower,
pretty
lower.
Yeah.
And even with that, there were some DLTs. There were some grade 3, 4s, transaminitis, even amylase, just signals that these cells are still very potent. They're causing these inflammations, and they seem to have that phenotype that has been reported across CAR-Ts to be associated with prolonged, response and hopefully some CAR-T persistence. And so biologically, that could, also be very favorable. But also manufacturing, maybe it could go even better because you don't need to make as many cells.
Agree. And then, with this second, the Gracell, construct that you talked about, the other feature is it's a dual target. So, we can always debate whether CD19 is the, optimal second target, but, I mean, the data looks really good. And that's the other piece, how do we maximize what we can get out of, the CAR-T cell therapy as a strategy in myeloma, and try to make, multi-target CARs that are able to eradicate disease, and this elusive cure that we've been kind of chasing and talking about now, is something that we can do for myeloma. So, that's the other, I thought exciting thing. But I agree with all your comments.